So today's topic is clinical approach to neuropathy, especially diabetic neuropathy. And I'll be going through the approach which a neurologist would have. And basically, the topic has been divided as a general approach to neuropathy. And then we'll go into the pathophysiology of diabetic neuropathy. And my talk is going to be clinical oriented. So I'll be discussing more of 2 or 3 cases of diabetic neuropathy. And then how do we evaluate patients with diabetic neuropathy? And finally, the management of diabetic neuropathy, that is mainly the neuropathic pain management, which is a very important situation which we face, most of us, including endocrinologists, dietitians, physicians, neurologists, orthopedicians, everybody comes across this diabetic neuropathic pain. So how do we go about this? So it's going to be a clinical talk, and rather than going into much of theory, we'll have a general approach which we should have when we see patients in our busy clinic. So whenever we think of neuropathy, the basic approach does not change. So be it diabetic neuropathy or some other neuropathy, we should have a basic approach, because diabetes being such a common condition, it may be a comorbidity in most of the patients, and the neuropathy may not be related to diabetes mellitus in few of the cases. So we should have a broad approach to neuropathy to find out the exact cause, whether it's a diabetic neuropathy or some other neuropathy which is occurring in a diabetic patient. So this is the general approach to any neuropathy which we see. So first thing is the time course, or what was the onset of the neuropathy. So whether it's acute neuropathy, whether it's a subacute or chronic neuropathy. The duration for acute neuropathy is less than 4 weeks, subacute is 1 to 2 months, and chronic is more than 2 months. Now, acute neuropathy in a diabetic patient could be some severe neuropathy like mononeuritis multiplex, or it could be a Guillain-Barré syndrome, which is occurring in a diabetic patient. So acute onset of severe neuropathy is not a diabetic neuropathy, but it's some other neuropathy which is present in a diabetic patient. Second is, what is the symmetricity of the neuropathy, whether it's a asymmetric neuropathy or a symmetric neuropathy. Usually the diabetic neuropathy is a symmetric neuropathy. So if we get an asymmetric neuropathy in a diabetic patient, it is likely to be a mononeuritis multiplex or a pressure palsy or some other etiology which is giving rise to the neuropathy. Third is, what is the distribution of the neuropathy, whether it is predominant proximal or predominant distal neuropathy. As we all know, the metabolic diabetic neuropathy is predominantly a distal neuropathy. So it affects the distal lower limbs first and then the distal upper limbs. But if we get a proximal weakness or proximal involvement in a diabetic patient, so it is unlikely to be a simple diabetic metabolic neuropathy. It is likely to be some other neuropathy like a CIDP, that is chronic inflammatory demyelinating polyneuropathy, which is an immune mediated neuropathy which is seen in diabetic patients. So the proximal involvement can tell us that there may be an immune involvement or immune pathogenesis to the neuropathy. Similarly, diabetic amyotrophy, again, you will have proximal asymmetric involvement predominantly affecting the lower limbs or the thigh muscles. So the distribution becomes very important. So where is the onset of the neuropathy, whether it's upper limb or lower limb onset? Usually the neuropathies are lower limb onset, and diabetic neuropathy is no exception to this rule. But some neuropathies can affect the upper limb. For example, lead poisoning. Lead poisoning is one motor neuropathy which can affect the upper limb. Then there is some condition called as mononeuritis multiplex or multifocal motor neuropathy with conduction block. So these conditions can affect the upper limb. So there are neuropathies which can preferentially involve the upper limb. Similarly, porphyria can affect the upper limb. Then what is the progression or the course of the neuropathy, whether it's a progressive neuropathy or a relapsing remitting neuropathy? Then whether it's a motor neuropathy, whether it's a sensory neuropathy, or it's a combination of motor and sensory neuropathy. So usually the diabetic metabolic neuropathies are sensory motor. So sensory is more involved while motor is less involved, and it is symmetrical, predominantly lower limb involvement. So that is the prototype diabetic axonal neuropathies. Now, what about the autonomic involvement? Now, autonomic history is a very important part of a neuropathic disorder. And quite often we miss the history of autonomic disorders because it requires history taking, and many of the time the patients will not volunteer the symptoms of autonomic neuropathy. So what are the symptoms of autonomic neuropathy which we ask in the bedside or when we see patients? So the symptoms, from if you go from head downwards to the foot, so in the eyes there will be difficulty in the pupillary accommodation, so some visual blurring when they go from dark to bright spot place, or bright place to a darker environment. So visual blurring will be there due to impairment of the pupillary accommodation. So that is one symptom. Second is dry mouth, excess thirst. Then third is the resting palpitation, postural hypotension. So the patient, when they get up from the lying down position, there may be some giddiness which can occur. So that is postural hypotension. There may be resting tachycardia. There may be abdominal bloating, abdominal distension, early satiety. There may be alternating diarrhea and constipation. And in males, erectile dysfunction may be a very important symptom. Then dryness of the skin, loss of hair, change in the nails, or the trophic changes. So these are all features of autonomic neuropathy which we should ask in detail when we see these patients. Then third, eighth point is the small fiber or large fiber neuropathy. So how will we know that a neuropathy is a small fiber neuropathy or a large fiber neuropathy? So usually the large fiber neuropathies involves the large fibers, that is the A beta fibers and the A alpha fibers. So the symptoms of the neuropathy will be uh, weakness of the limbs. So the patient will be complaining of distal weakness of the toes, slippage of chappals, difficulty in walking. There will be ataxia. When you examine the patient, there will be motor involvement, motor weakness, and sensory loss in the form of sensory impairment of pain, temperature, vibration, as well as the ankle jerk will be lost, and you will have ataxia, sensory ataxia. Rhombox will be positive, and the toe, the position sense of the toe will also be lost. So this is a classical large fiber neuropathy. While the small fiber neuropathies, it becomes really difficult to diagnose because the patient will complain of multiple symptoms. They will be having severe pain in the legs, there will be burning sensation, there will be paresthesias and all those things. But on examination, there will be no objective finding. So when you examine the patient, the motor power will be normal. The sensory examination, there may be minor abnormalities, otherwise no gross sensory loss. The ankle jerk will be preserved, and the rhombox will be not will be negative, and there will be no ataxia. So overall, the patient appears normal, but is having a lot of other sensory symptoms. So that is the classical small fiber neuropathy. So sometime in diabetes, you may get just a small fiber neuropathy. So unless you have a high index of suspicion, you may miss the condition. Then comes the axonal and demyelinating neuropathy. So now the axonal and the demyelinating neuropathy, the nerve conduction study may be very helpful to find the axonal and the demyelinating neuropathy. You are having certain patterns, like in demyelinating neuropathy, there will be prolongation of the distal latencies, the conduction velocities will be reduced, while in axonal neuropathy, the CMAP, that is the compound muscle action potentials, will be reduced, but the velocity and the distal latencies are preserved. But clinically, how can you say a neuropathy is axonal or it is demyelinating? So there are a few points clinically which can be helpful to tell whether a neuropathy is axonal or demyelinating. Now, axonal neuropathies are predominantly distal. Axonal neuropathies are associated with wasting. So there will be wasting, distal involvement, and the reflexes, only the distal reflexes will be involved. The proximal reflexes will be normal. For example, patient has distal weakness and wasting, but when you examine the supinator jerk is absent, the ankle jerk is absent, but the biceps and the triceps is present. So that is the feature, and there is no wasting in a demyelinating type of neuropathy, while in axonal there is wasting. And then nerve thickening may be seen in a demyelinating neuropathy, while in an axonal, the nerve thickening is not seen. So why is it important to say whether a neuropathy is axonal or demyelinating? It is important because the prognosis and the treatment may be different if it's a demyelinating neuropathy. If it's a diabetic associated demyelinating neuropathy, then it is likely to be a immune mediated neuropathy. So it may not respond to the control of the sugars only. So you may have to give immunomodulators, sometimes IVIG and steroids, etc. may be needed. While if it's an axonal neuropathy, then you know it is directly related to the diabetes. So you have to just control the sugars and give symptomatic management for the neuropathic pain. So the prognosis is again different. Demyelinating neuropathies respond to immune modulating treatment like IVIG, etc. While axonal neuropathy, the prognosis may not be good because it may not be completely reversible, while demyelinating neuropathies may be reversible. So to know the type of neuropathy, which may help us to manage the patient better as well as to prognosticate the neuropathy. Now coming to cranial nerve involvement, we all know some neuropathies can cause cranial nerve involvement. The most common is Guillain-Barré syndrome. Then Hansen disease, leprosy can cause involvement of the facial nerve, branches of the facial nerve. Similarly, cranial nerve involvement is quite common in diabetes also. So we know in diabetes you may get third nerve involvement, sixth nerve involvement, seventh nerve involvement. So cranial nerve involvement we have to check in all sorts of diabetic neuropathies. Then hereditary and acquired. Some of the neuropathies, there may be hereditary neuropathy. So you have to ask the history of family history of a neuropathy because there may be some underlying hereditary neuropathy, and along with that, there may be diabetes which may be associated. Then exposure to drugs and toxins, very important. We all know many medications can give rise to neuropathy. Suppose a diabetic patient develops a cancer and he is under treatment with chemotherapeutic agent. So the neuropathy may be partly caused by the chemotherapeutic agent. If the patient is on antibiotic like metronidazole or antituberculous medication or antiretroviral therapy, that may be causing the worsening of the neuropathy. So exactly we should know what all medications the patient is taking and whether there is any contribution from the medications to the neuropathy. Then toxins, certain toxins like arsenic, lead, bismuth, and various other toxins, heavy metal toxins, the traditional medicines which are being used, like in India, we use the Siddha medicines, Ayurvedic medicines, and many heavy metals are being used for medicinal purposes. So these heavy metals may be an important cause of neuropathy, even in a diabetic patients. So always get the history of the drugs and the toxins in any patient with neuropathy, be it diabetic or non-diabetic. Second is the nutritional status is also important. Whether the patient is a vegetarian or not. In India, there are many people who are pure vegetarians. So they may be having a vitamin B12 deficiency, which may be associated in a diabetic patient, and it may be giving rise to a vitamin B12 neuropathy along with the diabetic neuropathy. And there may be metformin, which may be given for the diabetes, which can again worsen the neuropathy. So there may be a mixture of the causes of the neuropathy in such patients. So the nutritional history and the diet history is also very important. Then systemic illness, the patient may be suffering from some other systemic illness also. For example, the patient may be having a paraproteinemia or a multiple myeloma. So there may be bone pain, there may be evening rise of temperature, weight loss, and all those things. And that patient may be a diabetic as well. So this may be overlapping and which may be causing a neuropathy. So the background history of systemic illness like paraproteinemia, HIV, tuberculosis, then malignancies, sarcoidosis, and all those things also has to be taken into account. So when we see a patient with neuropathy, it's not just labeling them as diabetic neuropathy, but you should have this stepwise approach of 12 to 13 points, which can tell us what this type of neuropathy, maybe whether it's directly related to diabetes or it is something else. And these are quite easy things to be done. You can see this is primarily based on the history. Second thing is the examination, and maybe you may require a nerve conduction study. So apart from this, no other expensive investigations are required to go through this checklist of points which you should keep in your mind when you are seeing a patient with neuropathy. So coming to the pathogenesis of diabetic neuropathy, I'll not go into the details of this. You can read it in all the standard textbooks and journals are having this. So you are having a Schwann cell stress. So that is what is postulated, the hyperglycemia and the dyslipidemia and other accompaniments of diabetes give rise to mitochondrial dysfunction, reactive oxygen species production, which gives rise to DNA damage and endoplasmic reticulum stress. And there is damage to the Schwann cell, which is primarily due to the microvascular damage, which reduces the nerve blood flow supply involving the vasa nervosum. And second is direct neuronal damage, which can be due to demyelination, axonal loss, and all those things. So there is an ischemic element to the nerves, and second is the direct neuronal damage due to the mitochondrial dysfunction and all those things. And dyslipidemia may be correlated along with the hyperglycemia and both may collaborate to worsen the neuropathy. So this tells us that in diabetes, it is not just the sugars, but also the lipids and the other metabolic parameters, which may be very important in managing the diabetic neuropathy. Now we should know that the typical metabolic diabetic neuropathy is a dying back axonopathy. So what does dying back axonopathy mean? So whenever there is a metabolic damage to the axon, so the longest nerve fiber, that is the most distal part of the nerve, gets affected first. So the longest nerve fiber is affected, and the damage to the nerves start distally and then it spreads proximally. So that is the rule. So as we all know, the lower limbs are longer than the upper limbs in humans, and so as a result, the nerves of the lower limbs are longer than the upper limb. So the neuropathy, the axonal neuropathy due to metabolic damage, will start from the distal most longest nerve. So it's the lower limb nerves. And when it ascends and reaches up to the knee or just above the knee level, then it starts affecting the upper limb. So this is called as the glove and stocking pattern. And this is due to the dying back axonopathy. And this typically tells us that the neuropathy is due to metabolic axonal damage. So that is classically in a diabetic patient, it's likely to be a diabetic neuropathy. So if you get this glove and stocking pattern of neuropathy, then it is likely to be a diabetic neuropathy. Now, causes I've already mentioned: high blood glucose level, the duration of the diabetes is very important. The neurovascular causes due to the atherosclerosis or reduction in the blood supply to the nerves. Then autoimmune mechanisms may be there. There may be antibodies which may give rise to inflammation and damage to the myelin sheath. There may be compressive neuropathies, especially the carpal tunnel syndrome. We know carpal tunnel syndrome, the most important predisposing factor is diabetes mellitus. So that gives rise to the neuropathy. Then lifestyle is very important, especially alcoholism and smoking, which may again worsen the neuropathy. If you look at this picture, the obesity and the high cholesterol doubles the risk of the neuropathy in a diabetic patient. Secondly, high blood pressure increases the risk of neuropathy from 11% to 65% in diabetes, and also smoking 42%. So it means that the metabolic profile, the lipids, the cholesterol, the weight of the patient, the blood pressure, everything is important, and you have to control the entire metabolic profile of the patient to have a better outcome in a neuropathic patient. And also tell them to avoid alcohol. We know alcohol causes worsens neuropathy, and it also causes neuropathy. So alcohol we all know, but smoking again is an important risk factor for neuropathy. So patient has to stop smoking as well, apart from stopping alcohol intake if they are taking alcohol. Now I'll just have a brief case report. So this will tell a type of neuropathy which can occur in diabetes. So this is a 28-year-old lady and 14-year history of type 1 diabetes with poorly controlled sugars, with a HbA1c level of around 10 to 14%. So it's a quite high HbA1c level, but there was no symptoms of neuropathy. Patient had no other symptoms, no burning sensation, no tingling, paresthesia, nothing suggestive of a neuropathy. Now she gets admitted to the hospital due to a urinary tract infection, which has given rise to a diabetic ketoacidosis, and she's admitted in the hospital. And as we all know, DK is a medical emergency. The patient is treated with IV fluids and insulin has been started, and the glucose control has been brought during the hospital, and there's a rapid control of the sugars, and she's discharged, and her sugar readings are quite okay after that. And then 3 weeks later, she goes home and then comes back with a severe burning paresthesias in her hands and legs, and without any associated weakness or any objective findings. She's evaluated, examination is absolutely normal, but the patient is completely in distress with lot of sensory symptoms. She's having allodynia and hyperalgesia in the distribution of the pain. So when you touch the skin, she's not allowing you to touch the skin. So there is allodynia and hyperalgesia. And the nerve conduction and the EMG is ordered, the standard nerve conduction test, and this is found to be normal. And then the patient is referred to a neurologist. At the time of the hospitalization, at the time of the neurological evaluation, that is 6 weeks after hospitalization, the HbA1c has been reduced from 12.2 to 8.1%. So 4% reduction in the HbA1c over a very short course period of time is there. On neurological examination by the neurologist, there is a evidence of a length dependent small fiber neuropathy. That means the strength is normal, reflexes are normal, and sensation is normal. However, there is hyperalgesia and some reduction in the pinprick and temperature. So the pain and the temperature is mildly reduced and hyperalgesia is there. So this is the only finding in the examination. Rest of the findings are absolutely normal. So the small fiber neuropathy is suspected by the neurologist and a skin biopsy is done, which shows a severe small fiber neuropathy with absent fibers in the distal lower limbs. That is distally, but proximally it is normal. So this suggests of a length dependent small fiber neuropathy. Now she is managed for the neuropathic pain with tricyclic antidepressants, gabapentin and all those things. And she's also found to have a retinopathy as well. So this is the story of this patient. So the diagnosis is treatment related neuropathy or an insulin neuritis, which was the old term which was used. And this is the classical example of a small fiber neuropathy which can occur in diabetes mellitus. It's a severe small fiber neuropathy and there may be autonomic involvement as well. And it occurs when there is a rapid and dramatic control of the sugars, especially the patient is admitted suddenly and then if a IV insulin or subcut insulin is started for the patient. Now we should know that the treatment related neuropathies, the more severe the reduction of HbA1c over a short period of 3 months, the more severe the neuropathies. For example, if you see here 2 to 3 HbA1c, the neuropathy is predominantly distal. While if it is 4 to 5, the neuropathy is more proximal, is going more proximal. And if it is 6 to 7, then you can see it's almost involving the entire body. So this shows that a rapid reduction in HbA1c may be a predisposing factor for the treatment related neuropathy. Now coming to a second easy case, a very practical and common situation which we see in our practice. So this is my own patient. So 60-year-old patient, male patient, diabetic since 12 years on insulin and oral hypoglycemic agents with poor sugar control. He is having systemic hypertension, the coronary artery disease, post CABG status on dual antiplatelets and statins. There is a past history of mild back pain on and off, left leg pain which increases on walking. Now he is complaining of a left-sided thigh pain with radiation of the pain occasionally below the knee to the shin and to the back since 2 weeks. So this is the present complaint. The pain is very severe and increases in night. And since 3 days, he had developed weakness of the left lower limb, which is manifested by fall while walking. So the patient has buckled and fell down. And there is severe pain in the left leg, which is radiating to the back. And there's a mild back pain since the past also, which very mild history is also there, with some claudication like history in the lower limb, which increases on walking. Now, when I examined the patient, general examination, there is mild pallor, distal pulses are a bit reduced and weak bilaterally. Power in the upper limb is normal. Lower limb, you can see left side hip flexion is weak, hip adduction is weak, knee extension is weak. So these three movements are quite weak, while the ankle dorsiflexion, plantar flexion, and the extensor hallucis is quite okay. Right lower limb is normal. Sensory loss is seen distally, bilaterally. The knee jerk in the left side is absent. Right side is present, and the ankle jerk is absent bilaterally. So these are the clinical findings which I could make out. So the provisional diagnosis was lumbar radiculopathy, left lower limb neurodeficits. So there is a proximal lower limb weakness, and diabetic neuropathy is also there since there is a distal sensory loss and ankle jerk loss is there. And probably peripheral vaso-occlusive disease, that or POAD is there because the distal pulses are reduced. Now, this was the scan which was done outside. And after that only the patient was referred to me because the back pain was there and radicular pain was there. So the MRI was done, and you can see this is the MRI T2 weighted image, sagittal view. So this is the L4, this is the L5. So you can see in between the L4 and L5, there is a large disc here, which is protruding into the space here. And you can see here, this is the axial cut at this level. You can see there is a large disc which is compressing the root. That is, this is L4, L5. So this is compressing the L5 root here significantly. And you can see the other roots here. So this is the other roots which are seen here. So there is a significant compression of the L5 root. due to lateral uh, disc disease. It's a lateral posterolateral disc disease. So the neurosurgeon and the nerve conduction study is also done, which shows a motor sensory axonal neuropathy and bilateral S1 radiculopathy and left L5 radiculopathy. This is the nerve conduction study result. So with this report, the patient was advised surgery by the neurosurgeon, and then they came for a second opinion to the neurologist to see whether surgery is really required or whether the patient can be treated on medications. Now, with the findings which I've already explained, the question is whether the surgery is warranted. Are the deficits which are explained by the seen during examination is explained by the MRI findings? What else can be done? Now, if you look at the deficits here, it is predominantly proximal, left hip flexion, adduction, and knee extension. So what are the root value of hip flexion? So hip flexion is L1, hip adduction is L2, and knee extension is L3. So there is a predominant weakness in the distribution of L1, L2, and L3. While the distal weakness is predominantly due to distal ankle jerk loss and sensory loss is predominantly due to a diabetic neuropathy. And you can see the disc is around L4, L5. So what should be the weakness if there is a L4, L5 or L5 root compression? So the weakness should be predominantly distal. It should be involving the dorsiflexion and the inversion movements or the extensor hallucis longus. It should not be proximal. And if proximal is involved, it should be in the hip extension and the abduction movement rather than the adduction and the knee extension movement. So the L5, S1 movements are predominantly hip extension and hip adduction and dorsiflexion and the extensor hallucis and the inversion movements. But these movements are spared rather than the hip flexion, hip adduction and the knee extension is affected. So that means this is not pertaining to the MRI finding. The clinical findings are not matching with it. So we performed a EMG of the proximal muscles. So we sampled the quadriceps muscles with the EMG, and there is fibrillations which is seen in the quadriceps muscle. And during the EMG examination, we examined the quadriceps muscle, which showed severe tenderness of the quadriceps muscles. So the here diagnosis was diabetic amyotrophy or diabetic radiculoplexico-neuropathy, and it's not a diabetic, it's not a lumbar radiculopathy. And because of this, we'll not go for a surgical treatment in this patient. We'll rather manage the patient conservatively and symptomatically. And as we all know, these patients usually the deficits will improve over a period of time, and there may be improvement without any surgery or any other intervention. So we should leave these patients alone and manage them symptomatically. And diabetic amyotrophy is not a very common condition. It's seen in 1% of the diabetic patients, and typically lower extremity involvement, acute asymmetric focal onset of pain followed by weakness and wasting. So the pain will be very severe, acute onset, severe pain followed by wasting and weakness, which will be there. That should give you a clue that it is likely to be a diabetic amyotrophy. And the progression occurs over a month, and it is followed by partial or full recovery in most of the patients. Over a period of 6 months to a year, most of the patients improve. Distal involvement is rare, but it can occur. And the condition can be bilateral also, and it can be symmetric over time. So it's not just unilateral, it may spread to bilateral involvement. This is one of my patients. You can see there is severe wasting of the quadriceps muscles here, and right side also that's mildly wasted. So it's a bilateral condition, more on the left side compared to the right side. And it's also called as the Burns-Garland syndrome, and you can see there is a wasting of this thigh compared to this. So always look for the wasting and then squeeze the thigh. You can get severe pain. You examine for the proximal weakness, the hip flexion, hip adduction, and the knee extension are the key movements which are involved, and the knee jerk will be absent in most of the patients. So this could give us a clue that it is a diabetic amyotrophy. The problem is that the diabetic amyotrophy, there may be associated back pain, there may be sensory symptoms, there may be a radiating pain which looks like a lumbar radiculopathy. So wherever in confusion, you should do the lumbar MRI also in such patients and correlate the MRI findings with the clinical findings, and then decide on what could be the etiology of the back pain and the radiating pain. Now, what are the various neuropathies which can occur in a diabetic patient? So the neuropathies in the diabetic patient can be a typical large fiber neuropathy, which I have mentioned, sensory ataxia, ankle jerk loss, distal weakness, distal sensory loss. So that is the typical diabetic neuropathy. It can be a small fiber neuropathy also. All examinations normal, only some pain temperature loss and severe pain of the patients. Rest of the findings are not there. So that's a small fiber neuropathy. There may be a proximal motor neuropathy, which, like I've already showed, the diabetic amyotrophy. There, it can be predominantly quadriceps involvement or proximal involvement. Then there can be mononeuropathies which can occur. For example, there can be third nerve palsy, there can be sixth nerve palsy, there can be a truncal neuropathy which can occur around the trunk. So this can mimic a thoracic radiculopathy. So a thoracic radiculopathy like presentation can occur in a diabetic truncal neuropathy. Then there may be a compressive neuropathy like median neuropathy, ulnar neuropathy, and the common peroneal nerve neuropathy. So these are the various presentations of neuropathy. Again, you can classify it as a diffuse neuropathy or mononeuropathy or a radiculoneuropathy, depending upon the involvement. So there are various sort of classification. One classification is symmetric and asymmetric involvement. So symmetric, you can go for acute and chronic. Now symmetric acute is diabetic, the diabetic neuropathic cachexia and the treatment related neuropathic. Symmetric chronic is the typical diabetic neuropathy, that is diabetic peripheral motor sensory neuropathy. It can be large fiber, small fiber neuropathy, autonomic neuropathy. And one thing which you have to remember is the CIDP, that is the diabetic CIDP, which is a immune mediated neuropathy. Asymmetric, again, you divide as acute and chronic. Acute is the classical one, amyotrophy, which I mentioned, and also the cranial neuropathies and the truncal neuropathy and the mononeuritis multiplex. Or it can be chronic, like the entrapment neuropathies, which are again asymmetric. So these are the various ways you can classify the diabetic neuropathy depending upon the pattern, the symmetricity, the whether it's a diffuse or focal involvement, etc. Now this is the classical diabetic third nerve palsy. You can see there is ptosis. The eye is deviated laterally, so that means the lateral rectus is overactive and the medial rectus is paralyzed. And the levator palpebral superioris is not working, so there is ptosis. And you can see the pupil is not seen here, but the pupil is reacting to light. So if you are getting a third nerve palsy with a normal pupil or a pupil sparing third nerve palsy, then it is most classical of diabetic neuropathy. While if the pupil is involved in a diabetic patient with headache and pain, severe pain, then always try to rule out an aneurysm, which may be giving rise to the third nerve palsy. So always look for the pupil, which will give us a clue whether it is related to diabetes or related to some secondary causes like aneurysm or some other etiology. Now, just a brief word about small fibers. We all speak about large fibers, and the classical neuropathy is a large fiber neuropathy. So we do not miss a large fiber neuropathy, but a small fiber neuropathy is the one which is usually missed by the physicians and the other doctors. So what are the small fibers? The small fibers are classically the A delta and the C fibers, and they classically control the pain and the temperature as well as the autonomic system, which are mainly controlled by the A delta and the C fibers. So in small fiber neuropathies, you will have lot of pain, lot of temperature and perception problems. There will be allodynia, hyperalgesia, and all those things. And associated with that, there will be autonomic dysfunction because the small fibers are getting involved. Now, it is difficult to diagnose because there is no objective clinical signs, and the routine nerve conduction studies will be normal. We should know that the nerve conduction studies, which are designed, are mainly designed to study the large fibers only. So the small fibers are not studied in the standard nerve conduction studies. And the test for the small fiber neuropathies are not widely available everywhere. So because of this, many cases of small fiber neuropathy are getting missed. Now coming to pre-diabetes, we all speak about diabetes mellitus and all those, and it's the commonest cause of neuropathy. But we should know that 10% of the pre-diabetes patients will have a neuropathy. So it's not that the sugar has to be really high to develop a neuropathy. Sometimes pre-diabetes itself can give rise to a neuropathy in 10%. So you can think of the magnitude of the pre-diabetic patients in the community, because pre-diabetes is so common. So the neuropathy related to pre-diabetes is also very common, and it may be a very common cause of neuropathy apart from the overt diabetes. and it may be the commonest cause of idiopathic neuropathy. So we have a lot of patients in which the cause of neuropathy is not known. And in these patients, pre-diabetes is one of the commonest cause of neuropathy. And also the impaired fasting glucose, HbA1c from 5.7 to 6.4, the lipid parameters, the blood pressures, all this may be related to the pre-diabetes status, which can give rise to the neuropathy. Now, alcohol. Many patients with diabetes may be consuming alcohol, so that may be again associated with the neuropathy. In few of the patients, I have seen that diabetes is well controlled, still the neuropathy is very severe. And when you ask the history, they may be consuming alcohol, which may be giving rise to the neuropathy. So always ask the history of diabetic patient alcohol intake in every diabetic patient. Then also there may be B12 deficiency and all those things. And there may be a myopathy which may be associated with alcohol intake, which may be giving rise to neurological weakness in the lower limbs. Now, when will you suspect a patient with diabetes is not having a diabetic neuropathy, or when will you think you have to investigate the patient more? So these are the conditions where you should think that the the neuropathy in the patient, it may not be related to diabetes. One is an asymmetric neuropathy. So if you're getting a asymmetric involvement, one side unilateral asymmetric involvement, think of something away from diabetes. Motor proximal weakness. If you're getting a proximal weakness, severe weakness, then it is unlikely to be diabetic neuropathy. It is likely to be an immune mediated neuropathy like CIDP or a diabetic amyotrophy or some that sort of neuropathy. Polyneuropathy. If there is a polyneuropathy which is rapidly progressive, so within days the patient is unable to move, patient is debilitated, then it is again unlikely to be a simple diabetic neuropathy. So in all these patients, you should work up the patient for B12, paraproteinemia, thyroid functions. You look for autoimmune disorders and so on. Now, metabolic, we all know diabetes is the commonest cause, and pre-diabetes, I've already mentioned, 10% of pre-diabetes will have a neuropathy. Now, CKD or chronic kidney disease, we all know diabetic patients develop the diabetic neuropathy gradually, and it may be an independent risk factor for the neuropathy. We all know uremic neuropathy may develop, and the CKD patients will have a lot of metabolic and toxic elements in the blood, which can give rise to the neuropathy. So it's an independent risk factor for neuropathy. Then chronic liver disease. Diabetic patients may have an associated CLD either due to a NASH, which may be giving rise to a CLD, and that CLD again may be a risk factor for the neuropathy. So when we see a patient in bedside with diabetes, so this is the basic approach which every doctor should have. You should get the history of the diabetes, the duration, the type of the diabetes, whether it is type 1, type 2, what is the control of the sugars, how well the sugar is controlled, whether the patient is taking the medications, whether the patient is on regular follow-up. You should have a look in the renal parameters, the urine routine, the albumin creatinine ratio, the frothing of urine for the just in the history. You can ask about that. You can ask about eye symptoms, any blurring of vision, any other things. Apart from the cataract, there may be a retinal involvement. The diabetic retinopathy may be there. So you ask history of that. Other causes of neuropathy you should rule out. You should ask about the diet, especially vitamin B12 deficiency, alcohol, and also occupational exposure to toxins and drugs, etc., which has to be asked. Then pre-diabetes status, you should ask the neuropathy history. We have to ask what is the onset of the neuropathy. All the 13 points which I have mentioned has to be asked. Then you examine the patient, do a good general examinations, look for the skin, trophic changes, the ulcer, look for the foot, how the foot is. Examine the neurological part correctly. You examine for the power, the reflexes. You examine the ankle jerk and the knee jerk. You examine the pain, vibration, joint position sense, and the rhombox. And then see whether it's a small fiber, large fiber, whether it's axonal, demyelinating, whether it's a symmetric, asymmetric, whether the cranial nerves is involved or not, whether it's a proximal neuropathy, whether it's a distal neuropathy, whether there is autonomic involvement or not, and whether there is exposure to drugs, toxins, whether there is any other systemic illness or not. So everything you examine and then do the nerve conduction study and the parameters, and then the entire checklist of 13 points is complete. And then you examine the vascular part also, because the neuropathy, the diabetic foot may have an ischemic and a neuropathic part. So you check for the distal pulses and see whether the circulation in the distal limbs are okay or not. So this is the basic approach, bedside approach with history, examination, and basic nerve conduction studies, which can tell us a lot about the neuropathy. And rather than going for a panel of tests for all the patients, this approach will help us to pinpoint the diagnosis and also minimize the number of the investigations which we need to do in such patients. So these are the investigations: fasting sugars, PPVS, HbA1c should be done, thyroid function test, ANA and B12 wherever required. Look for the target organ, that is albumin creatine ratio, renal function test, get a proper ophthalmological evaluation for the retina, and nerve conduction studies for the large fiber neuropathy. So these things I've already mentioned. Now, what about the small fiber neuropathy? How do you diagnose a small fiber neuropathy? So the classical test, which is the gold standard, is a skin punch biopsy. So you see this instrument which is used to punch out a small segment of the skin, and then they study it under the confocal microscopy, and this is the PGP 9.5, which is stained with the nerve fibers, and you can see there is a loss of the nerve fibers here, so which suggests of a small fiber neuropathy. So this is the most sensitive test and specific test, and we look at the nerve fiber density here, and that will tell us whether there is a small fiber neuropathy or not. But everywhere this test may not be available, and then the expertise for the test may not be available everywhere, though it's a very simple test, but it may not be available everywhere. So in that case, you need other tests. So one is a corneal confocal microscopy. This is, again, if you have a good ophthalmologist, you can do this. You can, it's a non-invasive test, and you can see this is a normal architecture, and you can see there's a loss of the nerve fiber layers. So this is one of the earliest uh, areas to be involved in a small fiber neuropathy. So you can pick up the neuropathy quite early if this is done. Again, it is not widely used in the clinical practice. Now, these are the various tests which are available for the small fiber neuropathy. There's a biotheziometer where you look at the vibration, then you can look at the pressure sensations, the touch sensation, all various machines are there. And the sensitivity ranges from around 60 to 70%, and it's quite handy and it can be used, and it's relatively cheap. But there are new tests which are arrived, which are there, like this is the pseudoscan test, which is for the sweat chloride levels, and which can chloride conductance of the sweat is there, which is tested, and it is quite handy and easy to do test, and the sensitivity of this test is more compared to the other tests which were available. So this is one test which is coming up, and then you can look at the color changes by some card test like thing. This is a skin biopsy, punch biopsy, which I've already mentioned. So based on the availability of this, you can choose whichever test is there which can use for small fiber neuropathy. But the gold standard for the autonomic and the small fiber neuropathy may be a QSAT test, which is again not available in most of the places. Even in India, we have it only in research institutions and big institutions. So for clinical practice, you can choose some of the tests which I have mentioned here for the evaluation of the small fiber neuropathy. This is one test which I've already mentioned, pseudoscan, which we have installed in our center here, and it is FDA approved, and it checks the sweat chloride levels, and the patient has to simply keep the hands over the electrodes here, the hands here and the feet here, and then they have to keep the hand pressed with some pressure, and then the sweat chloride levels are estimated through the sensors, and it will give a reading whether the patient has a small fiber neuropathy or not, and what is the intensity of the neuropathy, whether it's a large fiber, whether it's a severe or a mild to moderate type of small fiber neuropathy. It's a quite handy test, and what we have used it in some patients with small patients with small fiber neuropathy. What we did is we selected patients clinically who had symptoms and signs of small fiber neuropathy, and then we did a nerve conduction study, the standard nerve conduction study. And what we found that we had 13 patients, and in these patients, the nerve conduction study, you can see here, the nerve conduction study was normal in 11 patients. And in these patients, when we did the pseudoscan test, only 2 patients were normal in pseudoscan, but the rest of the patients we could find out that they had a neuropathy. So this shows that In patients who have a nerve conduction study, you have a 80 to 90% chance by the using the pseudo scan to detect a small fiber neuropathy. So this may be one easy to do and reliable and cheap test which can be done at a low cost in areas where the expertise of skin biopsy is not available. So this is the sensitivity 70 to 87.5%, and this is the specificity of this investigation. Now coming to the management of diabetic neuropathy, just briefly I'll just tell the headings and how is the approach of management of the diabetic neuropathy. So we all know the gold standard or the main thing for managing the diabetic neuropathy is glycemic control. So you have to control the sugars properly, give a good foot care so that the patient does not develop complications like ulcers and all those things. So foot care is very important. And then third part is the treatment of the neuropathic pain. Now we know that in type 1 diabetes mellitus, the stable and the optimal glycemic control is very important, and it can prevent the progression of the neuropathy. While in type 2 diabetes mellitus, control of sugar has a modest effect. So it is not so effective as in type 1 diabetes mellitus. And however, along with the sugars, you have to normalize the lipids, blood pressure, weight, and lifestyle modification should be there. There should be healthy diet, regular exercises, and all those things. So it's not just sugar, the entire metabolic profile of the patient has to be corrected in type 2 diabetes mellitus. Now, B12 deficiency, I've already mentioned. So you should rule out B12 deficiency and treat them if there is a B12 deficiency. And if you see that if the metformin is used for 5 years, almost 20% may develop a B12 deficiency. And especially in our place, there are a lot of vegetarians, so they are already B12 depleted. So metformin use may worsen the B12, reduce the B12 level. So that thing also we have to keep into mind. Then two more things. The American Academy Guidelines of 2021 mentions it. You should rule out depression and obstructive sleep apnea syndrome and other diseases which can affect the quality of sleep and other things which can affect the pain threshold in these patients. Now we all know the pain threshold is different for different patients. Now the pain threshold is affected by the personality of the patient, the mood status of the patient, and also the sleep parameters. So patients who are sleep deprived, patients who are having sleep disorders, patient who is having chronic insomnia, obstructive sleep apnea, patient who is depressed and anxious and is having psychiatric history, the pain becomes very severe and it does not respond to the medication. So you have to evaluate the patient for these conditions also, especially if the neuropathic pain is not responding to the standard neuropathic medications. Now also you should counsel the patient regarding the expectations they should have when we are treating the neuropathic pain. For example, in migraine, we all know it's a chronic pain disorder. And when we treat migraine with prophylactic medications, it is not that we are going to control the migraine in 100% of the patients. So we have to set the goal around 50 to 60%, that 50 to 60% of your headache we will control with the medication. Similarly, in the neuropathic pain, you have to counsel the patient, tell them that the target of control will be around 30 to 50%. And then the classes of medications, we all know the commonest drugs which we use is tricyclic antidepressants, the SNRI, that is the serotonin norepinephrine reuptake inhibitors like desvenlafaxine and duloxetine or venlafaxine. Third is gabapentinoids, pregabalin and gabapentin. And fourth group which we do not use commonly and which is missed commonly is the sodium channel blockers. Now, what are the various sodium channel blockers which can use in neuropathic pain? One is lamotrigine, second is lacosamide, third is oxcarbazepine, carbamazepine, and fourth is valproic acid. So these agents may also be used as good agents, especially in patients who are not responding to the first line medications. Now, this is the mechanism of the action of the medications, and I'll not go into the details. You can see some of the medications. So the major drugs act in the serotonergic and the noradrenergic pathway, that is the SNRI, tricyclic antidepressants, etc. Then the inhibitory, the alpha delta, the calcium channels, the gabapentinoids act, that is the pregabalin and the gabapentin. And then there are drugs like botulinum toxin, which acts on the presynaptic membrane. And there are various other drugs which are not commonly used, which acts in the postsynaptic and the excitatory neurotransmitter levels. And the opioids has multiple mechanisms of action. So basic drugs are in the serotonergic and the noradrenergic pathway, or the presynaptic calcium channels. So these are the major targets which we use in the common drugs. Now the initial therapy, you can choose the antidepressants or the anticonvulsant. Now the guidelines are not very clear which you should choose, but based on the efficacy wise, it is better to choose a gabapentinoid initially if the neuropathic pain is very severe. So if the patient is having a very severe pain, you need an agent which is going to control the pain quickly and give the patient symptom relief. So you go for a anticonvulsant group of medications like pregabalin or gabapentin. Now coming to pregabalin and gabapentin, both are almost similar molecules, but we all know pregabalin is more potent. So pregabalin is 4 times potent that of gabapentin, and we all know with potency comes side effects. So pregabalin has more side effects compared to that of gabapentin. So there is more dizziness, there is no more peripheral edema, facial swelling, pedal edema, and all those things which occurs with pregabalin. While gabapentin, the side effects are less, but the potency is also less. Now, if the patient is having a very mild pain, very light burning pain, and the pain is tolerable, patient has depression, sleep issues, then you go for antidepressant initially. You can go for amitriptyline or nortriptyline, or some depression and all are there, or if there is fibromyalgia which is associated, then you can go for duloxetine or desvenlafaxine or venlafaxine. So this drug, based on the intensity of the pain and the comorbidities, you can decide which drug you can go. There is no clear-cut guideline like you have to start this medication. Then the patient who failed with the initial therapy, if there is complete failure with the drug, then you can change the medication, go for the other group. Suppose if you are giving pregabalin and gabapentin, you can go for the antidepressant group. And if you see there is a partial response, then you can add or combine the therapies together and see. So you can give the combination of therapy because there may be a synergistic effect when you use combination of therapy. Now there may be other things which you may add on along with the combination of the drugs, like for local pain. Some patients may have local pain which may be there in a finger or some localized area. Then you can use a capsaicin cream or a lidocaine patch. Alpha lipoic acid may reduce the pain. There may be topical sprays, and also TENS, that is trans-electrical nerve stimulation, may also be useful for local pain. Now, opioid is a controversial topic. Different guidelines give different recommendations, but the recent 2021 American Academy of Neurology guideline is strongly against the use of opioids. However, in clinical practice, we can use it for a very short duration of period, especially for severe pain. When the patient is having refractory pain which is not responding to medication, a very short course of opioids may be a bit helpful in few of the patients, but you have to take into consideration the patient's age and a lot of other things before you give the patient opioid. Now, this is a chart from the continuum of American Academy of Neurology. So you can see they have given the drug classes as SNRIs, which is duloxetine and venlafaxine. And if there is depression and anxiety, this may be very good drugs because they are having good action in the depression and anxiety. However, you should look for the side effects like sexual dysfunction, glaucoma, restless leg syndrome, because this may worsen with this medication. So the comorbidity is very important. Tricyclic antidepressants, amitriptyline and nortriptyline. What is the difference between amitriptyline and nortriptyline? Similar to that of gabapentin and pregabalin. Amitriptyline is more potent, so it has more side effects. There is more dry mouth, there is more orthostatic hypotension, urinary retention, glaucoma, delirium, memory loss, and all the things are more with amitriptyline, while nortriptyline will have lesser side effect, but the potency is also less. And you should know the side effects. Cardiac disease, QT prolongation can occur, so ECG may be required. Patients with heart disease, arrhythmia, you should avoid the patients. Elderly patient, you should avoid orthostatic hypotension, sexual dysfunction. Patients with BPH and urinary issues, there may be sudden urinary retention with the amitriptyline, and glaucoma may also be precipitated. So have the comorbidities you should know, and especially in the elderly patient, you should go with a very low dose and titrate the medications very slowly. Then pregabalin and gabapentin I've already mentioned. So if there is a restless leg syndrome, insomnia, and tremors, this may be a good drug. But if there is edema, COPD, and also, you should try to avoid this medication because it may aggravate the edema and the COPD. Again, if there is a renal failure, again, pregabalin, gabapentin may worsen the tremors. We may create myoclonus. It can worsen the renal parameters, and it may cause encephalopathy and all those things. So be very careful whenever you are using these drugs, especially in CKD patients, because these drugs are renally excreted. Now, regarding the efficacy of the drugs, so this is one trial which shows that most of the drugs are almost similarly efficacious. So there is not much difference between the efficacy of the drugs. Now, what about the combination of the neuropathic medication? So this is one study, the COMBO-DN study, which was published in Lancet, and they have studied the patients and seen that. So this, you see, there's various combinations they have tried: amitriptyline pregabalin, AP, duloxetine pregabalin, pregabalin amitriptyline. So these various combinations are being used, and this is the combination, and this dark one is the monotherapy. So this is the monotherapy, and this is the combination. This is the monotherapy, this is the combination. This is the monotherapy and combination. You can always see that the combination works better than monotherapy. So what is the advantage? That one is synergistic effect, and second is, if you use a single dose, you have to go for very high dosage of the single drug, so which gives rise to side effects. And if you go for a combination, usually both drugs you can keep at a suboptimal level, so the side effects are not there, and there is a synergistic action. You can make use of the synergistic action. So combination is again quite good. And now there are combinations of pregabalin and duloxetine which are available, which is quite good. There are combinations of gabapentin and the nortriptyline, gabapentin and amitriptyline, pregabalin and amitriptyline. All these combinations are there. So with that, the pill burden also comes down. With a single pill, you have combination of medications, which can again be quite beneficial. So can be used depending upon the cases. Now there are topical applications like capsaicin, glycerol trinitrate spray, and all those things. Non-traditional medication like ginkgo biloba has been studied, and there are some evidence, not much evidence. And non-pharmacological treatment also has evidence. For example, exercises, cognitive behavioral therapy, especially if there is anxiety and depression, psychiatric illness, CBT can be quite useful in such patients. Capsaicin cream 0.075%, 4 times daily it may be applied. But we should know that there may be local irritation and burning, especially in this capsaicin cream. And TENS is again a good technique for reducing the pain in diabetic neuropathy. And some of the guidelines mention it as a good, useful method. And one important thing which I'd like to highlight here is spinal cord stimulation. So there are many trials and observational studies, and this is FDA approved. And there is moderate quality evidence to support the use of spinal cord stimulation in diabetic neuropathy. So this may be a future important treatment like TENS if it becomes available, though it's a bit invasive procedure. So it can be quite useful in the control of the refractory diabetic neuropathy pain. Alpha lipoic acid, it is present in most of the combination medications, and it may reduce the neuropathic pain at 600 mg. Valproate can be used especially in refractory patients. Carbamazepine, if the standard treatment has failed, it can be used. Now there is a newer opioid which is available, which is called as tapentadol. I don't know whether it's available in Bangladesh, but here we use it for short courses, and FDA has been approved it for the use of in the diabetic neuropathy, and also the American Diabetic Association mentions about it in the for acute treatment of neuropathies. But it should be last line, and it should have a limited use, and you should assess the risk benefit ratio and also assess the patient for side effects whenever you use tramadol or tapentadol. Vitamin E did not improve the neuropathy. However, the lancinating pain, it has shown that it can reduce the lancinating pain. So severe painful neuropathy, you may try vitamin E, but there is not much evidence. So this is the pie chart. This is the chart which shows the management of neuropathy. You consider the contraindications and comorbidities. Start with a single agent, and then you go on for a combination of medications. And then if there is no adequate pain control, you go for other treatment. Like you can go for opioids, local patches. You can add the other medications like alpha lipoic acid, vitamin E, and all those combinations may be tried. Or you go for TENS and the higher treatment, which is again available. So these are the neuromodulation methods which are available for the management of neuropathic pain, and out of which the spinal cord stimulation may be quite useful. Then TENS, which again we use quite commonly. Percutaneous nerve stimulation, PENS is also quite useful. So these things are there which can be used in our day-to-day practice, especially TENS, PENS can be used, and spinal cord stimulation, which may be the future management of diabetic neuropathy. This is the various evidence which is in the guidelines regarding the management of the neuropathy. And you can see here most of the groups, that is AN, NICE, ADA, IDF, Canada, and all those things, pregabalin and gabapentin has recommended as 1 and 2. So it changes in the various guidelines. Duloxetine is again 1 in few of the guidelines, 2 in a few of the guidelines. So there is nothing much to choose. Amitriptyline, venlafaxine, duloxetine, gabapentin, and pregabalin all have been recommended in the guidelines, either in 1 and 2. And then tramadol you see is not higher in the list. Tapentadol again, it's not very high. So they are 2 and 3. So it should be used lower down. And then you can see capsaicin cream. Some of the guidelines mentioned it as 2 and 3. And lidocaine patch again 2 and 2 here. Some of the guidelines mentioned it as a second line thing. So capsaicin cream and lidocaine patch may also be used. Botulinum toxin, which has been mentioned in some of the guidelines as the last resorts. Sodium valproate is there, while carbamazepine, lacosamide, lamotrigine, they have not been mentioned in the guideline. But again, for refractory pain, these drugs may be used. And the advantage is that for severe pain, which is not responding, I found carbamazepine, oxcarbazepine to be quite effective. And few patients in which there was severe neuropathic pain, intravenous lacosamide maybe again be useful because it is available as an intravenous formulation. So you can give it rapidly and the response may be seen. Similarly, sodium valproate may be helpful in severe neuropathic pain if it is a very acute severe pain not responding to the medications. So the take-home message from this presentation is there may be various types of neuropathy which can occur in diabetes mellitus. If the neuropathy is asymmetric and it is rapidly progressive in a diabetic patient, work up for other etiologies. We should know that pre-diabetes is a very important cause of neuropathy. Suspect small fiber neuropathy when examination and nerve conduction study is near normal, and do specific tests like skin biopsy, pseudoscan, or some other test for the small fiber neuropathy to try to diagnose small fiber neuropathy, because though the patient only has symptoms, and apart from symptoms, it has a lot of implication in the morbidity and the mortality of the patient, because we all know the autonomic nervous system is controlled by small fibers, and the autonomic nervous system is the most important system. It controls our respiration, cardiac, and all those things. So it has an effect on the mortality of the patient as well. Sudden cardiac arrest, cardiac arrhythmias, all this can occur in patients who are having a small fiber neuropathy and autonomic neuropathy. And the treatment options are many. Sugar control is the main aim, and then symptomatic management of the neuropathy with either monotherapy and combination therapy may be tried. So that is all from my end, and I thank all for a patient listening.